Bismillahirrahmanirrahim and Assalamu alaikum. Today, the topic of our discussion would be bladder trauma. Our learning objectives of today's presentation would be introduction, brief anatomy of the bladder, mechanisms of injury, types of different trauma to bladder, evaluation, management, complications, and long-term follow-up. Uh, Starting from the introduction, bladder injuries can result from two traumas basically. One is non-iatrogenic and other is iatrogenic. In non-iatrogenic, the trauma can be blunt or penetrating, and in iatrogenic trauma, we can have external and internal types, which we'll be discussing later on. Full bladder is always more susceptible to injury rather than empty bladder. The management varies from conservative to surgical, which aims directly to repair the injury. In adults, the bladder is located in the anterior pelvis that is enveloped by connective tissue and extraperitoneal fat. Anteriorly, it is separated from symphysis pubis by a prevesical space that is also called space of Retzius. The dome, which is the weaker part, is covered by peritoneum. The neck of bladder is held in position by puboprostatic and pubovesical ligaments. We can see in this the diagrammatic representation of the anatomy of male pelvis. This is showing the male bladder. You can see anteriorly the symphysis pubis, which is held together by puboprostatic ligament, which is covering the space of Retzius. Posteriorly, there is the non-villus fascia, which separates the bladder from.
कर्सर यूज करो पिक्चर्स को डिस्क्राइब करते वक्त.
Here we have the space of Retzius, and this we can see the puboprostatic ligament, which holds the bladder in position. Posteriorly, there is the non-villus fascia, which separates bladder from rectum. And here we can see the prostatic urethra, the prostatic urethral part of urethra, which and below it lies the urogenital diaphragm. In female, the anatomy is somewhat similar, but the difference lies in the female genital tract, which is just posterior to the bladder. Here we can see this is the uterus and the cervix, and below vagina, which is just posterior to the bladder. This is important because, as we'll show further, there are different types of injuries which results in the formation of vesico-vaginal fistula. So the anatomy is relevant in that aspect. Briefly, this is the internal part of bladder, which shows the bladder wall, which is majorly formed by the detrusor muscle. And from coming inside to outside, first it is the transitional epithelium, then the lamina propria, which is after which lies the submucosa, and then the detrusor muscle layer. And after it lies the prevesical fat. Here are the position of two ureteric orifices. So now coming to trauma, as we have been discussing in the earlier sections, it is defined as a physical injury or a wound to living tissue caused by extrinsic agent. It is sixth leading cause of death worldwide, and about 5 million deaths worldwide occur due to trauma and disability to millions more. Management of trauma is based on the ATLS guidelines. Bladder trauma, as we discussed, can occur as a result of blunt trauma, iatrogenic trauma, or penetrating trauma. Bladder injuries isolated resulting from the blunt trauma rarely. 81 to 94% of patients have significant non-urological injuries. Bladder injuries are 83 to 95% associated with pelvic fractures, and they occur only in 5 to 10% of pelvic fractures. Other associated urethral injury is 5 to 20% of cases. Bladder is generally protected from external trauma due to its deep location in bony pelvis. However, sudden force when applied to a full bladder can cause rapid increase in intravesical pressure, and that can lead to rupture without pelvic fracture. In this sort of injury, when there is sudden increase in intravesical pressure, the injury is usually intraperitoneal. We'll be discussing that shortly. Now, classification, we can classify on the basis of etiology and location. On the basis of etiology, we have it is due to blunt trauma, penetrating trauma, and iatrogenic. Iatrogenic can be external or internal. And on the basis of location, the bladder injury can be intraperitoneal, which is less frequent. Majority of the cases, the injury is extraperitoneal, about 80 to 90% of cases. And in some patients, we have combined intra and extraperitoneal injury. These are the few forms in which the trauma can occur. Blunt trauma we see in road traffic accident, history of falls, pelvic crushes. Penetrating trauma can be occur due to gunshot injuries, warfare injuries, or due to retained bony fragments. Iatrogenic injury, which is divided into external and internal. External can result from any surgical procedure. The most common is a result from gynae and obstetrical procedures. However, they can also occur in different urological and general surgical procedures. And coming to the internal iatrogenic trauma, they can result after TURBTs or sometimes after TURP. Extraperitoneal injury, which is most common, it is almost always associated with pelvic fracture about 80 to 95% of times. The highest risk for extraperitoneal injury is when the disruption of pelvic ring is more than 1 centimeter, the diastasis of symphysis pubis is more than 1 centimeter, and there are pubic rami fractures. When these three features are present, there is high chance of extraperitoneal bladder injury. Intraperitoneal bladder injury occurs when there is sudden rise of intravesical pressure, as the weakest point is dome of the bladder, so it can rupture due to intravesical rise of pressure. Risk factors which can contribute to bladder trauma are pre-existing any neuropathic disease, prior history of urological surgery, any malignancy, or the patient of any tumor who has a history of prior radiation. This is a table which summarizes the incidence of iatrogenic bladder trauma during various surgical procedures. The most common the most common injuries result from gynecological and obstetrical procedures, and amongst these, the most common surgery that leads to bladder trauma is hysterectomy. And while we do a robotic radical hysterectomy, its chance is about 4.3 to 4.5%. However, in laparoscopic and open surgery, there is also a significant chance. In general surgical procedures, we have abdominal cytoreductive surgery, which contributes the major position. And in urological surgery, there is the retropubic male sling procedure, which is used to treat incontinence that can cause bladder trauma mostly. Clinical indicators when we should suspect bladder trauma when the patient presents to us. These include suprapubic pain or tenderness, abdominal distension, or if the patient is in ileus, if there's inability to void or there is significantly low urine output despite of having desire. Hematuria associated with pelvic fracture is almost always associated with bladder trauma. Enlarged scrotum with ecchymosis, and after if we have free intraperitoneal fluid and ultrasound or CT scan, that also indicates intraperitoneal bladder injury. And uremia raised creatinine can occur due to intraperitoneal absorption of urine that leads to a false elevation in serum creatinine levels. This is the American Association of classification, how we classify the bladder injury. It is classified from grade 1 to grade 5. In grade 1, there is just a hematoma or a partial thickness laceration of bladder. The hematoma is intramural hematoma. In grade 2 injury, the laceration is extraperitoneal and it is less than 2 centimeter. In grade 3 injury, the extraperitoneal laceration will be more than 2 centimeter, or intraperitoneal laceration will be there less than 2 centimeter. Both of these will come in grade 3 injury. In grade 4, the laceration would be intraperitoneal, that would be large and it would be more than 2 centimeter. Grade 5 includes complex injuries that can be intraperitoneal or extraperitoneal, that include the bladder, neck, or may include the ureteral orifices. The grade 4 and 5 injuries always require surgical repair. However, there can be conservative management of grade 1 to 2. We'll be discussing this in the management portion. This diagram just explains the classification which we were discussing. The first one is grade 1, which shows the intramural hematoma over left lateral surface. The second picture shows grade 2 injury in which there is small extraperitoneal injury that's less than 2 centimeter. The next picture shows a larger extraperitoneal injury which is more than 2 centimeter, or it also includes smaller intraperitoneal injuries less than 2 centimeter, which is shown in the next picture right here. In grade 4, the intraperitoneal laceration would be more than 2 centimeter, like here it is shown. And in grade 5 injury, it will be complex injuries which can include the ureteral orifice or the bladder neck, which always warrant a surgical repair. So coming to the investigations, basically there are three modes of investigation which can be used. Cystogram, which we perform oftenly, it can be of two types: of plain cystogram and CT cystogram. In certain circumstances, we can have to also perform cystoscopy or ultrasound to confirm our diagnosis. Cystography is the preferred modality for non-iatrogenic and suspected iatrogenic bladder trauma in post-op setting. Both plain and CT cystogram have comparable sensitivity, about 90 to 95% sensitivity and a specificity of 100% if performed in a proper way. Now coming to indication when we have to go for CT cystogram. Absolute indication after blunt trauma is gross hematuria associated with pelvic fracture. About 30% of patients have bladder trauma. Relative indications after blunt trauma: gross hematuria without pelvic fracture, or there is a pelvic fracture with microhematuria. This is a relative indication. A penetrating injury of buttock, pelvis, or lower abdomen with any degree of hematuria that would warrant a cystogram. Retrograde cystogram is nearly 100% accurate if performed precisely. In cooperative and cautious patients, the bladder should be filled up to a sense of discomfort, and otherwise, we generally fill bladder up to 350 mils. If it is filled less than that, there's a significant chance of missing any injury. In plain cystogram, there should be three images that must be obtained. The first, we get a control image, then a full bladder image, anterior posterior, in a drainage film. A drainage film is necessary to see because posterior extravasation of contrast that can be missed in just the filling film. So to see that, we have to have a drainage film. Here we have shown two diagrams of a plain cystogram which differentiate between how image would look in an intraperitoneal or extraperitoneal rupture of bladder. In the first image here, we can see the contrast extravasation, and it is lining the bowel loops, which is showing that the injury is intraperitoneal. In the second image, there is a flame-shaped collection, which is significant for extraperitoneal injury. We do not see any contrast extravasation inside the peritoneum, or that is highlighted by the bowel loops. So this is quite pathognomic for extraperitoneal injury. Now this is again a picture of an extraperitoneal bladder rupture. Here we can also see that the contrast is extravasated into the scrotum downwards here. And in the upper aspect, this is a flame-shaped collection as we were just seeing. So this is an extraperitoneal injury. And here we can see that the contrast extravasation goes in the peritoneal cavity. Now this arrow, this is showing that there is contrast in the left paracolic gutter, that is the intraperitoneal part, and here it is lining the bowel loops. So this image shows that the injury is intraperitoneal. Now, the CT cystogram is superior in identification of bony fragments in the bladder and bladder neck injuries, as well as concomitant bladder injuries. In many instances, when there is concomitant bladder injuries or cases of blunt trauma, a CT cystogram is performed, which is superior in certain aspects. Bladder must be filled in retrograde manner with contrast material diluted up to 2 to 4% to avoid a scatter artifact. Cystoscopy is sometimes used. It is the preferred method for detection intraoperative injuries, which can be identified at the time of uh, surgery during cystoscopy. It localizes the lesion in relation to the position of trigone and ureteral orifices. And during cystoscopy, lack of bladder distension suggests a large perforation. Ultrasound alone is insufficient. It just can be used to visualize intraperitoneal or extraperitoneal fluid collection. And if we have to place a drain for the removal, that can be done with ultrasound guided. Otherwise, alone it is insufficient, and we have to perform a cystogram to notify the injury. Now, coming to the management portion, the management can be conservative and surgical. Conservative management comprises of clinical observation, continuous bladder drainage, and antibiotic prophylaxis. It is the standard treatment of uncomplicated extraperitoneal injury and intraperitoneal injury in the absence of peritonitis and ileus. If the intraperitoneal injury is small, that is less than 2 centimeter, and as we were discussing the classification that comes in grade 2, it can be observed and managed in selected patients. If the lesion is larger, then intraperitoneal drain must be placed. In these situations, when conditions are ideal, urethral catheter management alone is enough and it heals the bladder. In conservative management, the catheter should be of larger size, usually 22 to 24 FR catheter should be used to promote adequate drainage. Cystography is necessary to verify complete healing before catheter removal. That's usually performed after 2 weeks of injury. In cases of extravasation, in the cases of extravasation that is still present after 2 weeks, we have to continue with bladder drainage until radiological confirmation of healing. We have seen it radiologically that the healing has occurred. Otherwise, we can continue with bladder drainage. Antibiotics should be, however, continued for 7 days to avoid infection. Now, this is an example of a patient who had an extraperitoneal bladder injury that was successfully managed just by placing a large bore catheter and conservatively. In first image, we see a dense flame-shaped pattern of contrast, which we were just seeing is suggesting the extraperitoneal injury. This patient was managed by bladder drainage alone, and after 2 weeks of catheter drainage, we have the second image, which shows a completely healed bladder with no contrast extravasation. There's some key points in which indicate the immediate repair of bladder injury, in which there is a very minimal or no role of conservative management. The intraperitoneal injury that has resulted from an external trauma. In these sort of patients, we have to repair the bladder. If there is penetrating or iatrogenic non-urological injury, inadequate bladder drainage or clots in urine. If we have placed a catheter for, as conservative management just mentioning, but the drainage is insufficient or there are clots in urine, so it signifies that the injury is large and maybe it would need surgical repair. If this bladder neck injury or rectal or vaginal injury, it will require repair. If there's open pelvic fracture, a pelvic fracture that requires open reduction and internal fixation by the orthopedic colleagues, then we have to perform the bladder repair and selected stable patients that are undergoing laparotomy for other reasons. Now, if there is a patient is having a laparotomy for other reasons due to any gut injury or and we concomitantly found that there is a bladder injury. Now, whether it is even an extraperitoneal injury, we can repair it that time because the patient is already open for laparotomy. And then if there are bone fragments projecting into the bladder, in this case, the bladder drainage alone will not cause the heal. We have to remove the bone segments and repair the injury surgically. Surgically penetrating or intraperitoneal injuries should be managed with immediate operative repair. These injuries are often larger than suggested on cystogram, and they are unlikely to heal spontaneously. Delayed in presentation or diagnosis can lead to prolonged leak of urine, which may cause chemical peritonitis or abscess. So, timely diagnosis and repair is essential. When operating without prior imaging, the ureteric orifice should be inspected for clear efflux of urine. Ureteral integrity may be confirmed by retrograde passage of ureteric catheter or IV administration of contrast to confirm the ureteral integrity. If there is a ureteric injury, it can involve the ureteric orifices or it can be a intramural injury. This will always warrant primary closure with stented reimplantation of the ureter and a perivesical drain. In such a repaired bladder, cystogram can be obtained after 7 to 10 days. And earlier there had been a concept of having double drainage or SPC drainage also, but several studies have suggested that there is no additional benefit which is obtained by placing a suprapubic catheter. So only urethral catheter is placed for conservative management. Now, coming to surgical management, that how do we repair the bladder? The basic techniques that include we have to remove the devitalized tissue, removal of any foreign body, removal of intravesical clots, and then bladder is repaired in two layers. Uh, in one of the first layer is the mucosa, which is repaired usually by Vicryl 30, and then the muscularis. It should be repaired in double layer always. In cases of concurrent rectal or vaginal injury, the both organ walls should be separated. The overlapping suture lines should be avoided. There must be a difference. They should not be the suture lines should not be parallel to each other. And if possible, we should always try to interpose a viable tissue between the repaired structures, such as a mentum or. And the complications of bladder injury usually result from delayed presentation or misdiagnosis. Early diagnosis and management promotes excellent results and minimal morbidity. However, serious complications can be due to delayed presentation or if the diagnosis is missed or the pelvic trauma was of significant, it was devastating pelvic trauma. Unrecognized bladder injuries can manifest as azotemia, acidosis, fever and sepsis. Patient can present as anuria or low urine output, peritonitis ileus, and urinary ascites. In unrecognized bladder, neck, vaginal, or rectal injuries, there can be very devastating complications. Patient can present with incontinence, fistula that can be a vesicocutaneous fistula, that can be a vesicovaginal fistula, depending upon which part of bladder is injured, and it has a difficult delayed major reconstruction if it is presents lately. Severe pelvic trauma may cause transient or permanent neurological injury, causing voiding difficulty despite adequate bladder repair. After managing another important part is how we follow up these patients. The conservatively treated bladder injuries are followed up by cystogram to rule out any extravasation and to ensure that the bladder has healed. First cystogram is performed after 10 days of surgery. In that cystogram, if this persistent leak Cystoscopy can be done to rule out bony fragments in the bladder, and then cystogram is performed after 7 days. After operative repair of simple bladder injury, catheter can be removed in 5 to 10 days without cystogram. This is in case of a simple bladder injuries. In cases of complex injuries that include trigone or ureteric reimplantation or risk factors of delayed healing, cystogram is advised before catheter removal. For conservatively treated internal iatrogenic bladder trauma, extraperitoneal injuries, catheter is placed for 5 days, and in intraperitoneal injuries, catheter is placed for 7 days. These are the guidelines of last year's 2022's guideline, which tell about the different points we have discussed. For example, perform cystogram in case of suspected iatrogenic bladder injury in postoperative setting. Cystogram is also performed in the presence of visible hematuria with pelvic fracture. To perform cystogram with active retrograde filling of the bladder with diluted contrast. Cystoscopy is done to rule out bladder injury after suburethral sling procedure by the retropubic root. The suburethral sling procedure has a high risk of bladder trauma, so in this case, cystoscopy is routinely performed. Manage a blunt extraperitoneal bladder injury operatively in cases of bladder neck involvement and associated injuries at the time of that require surgical intervention. These are the strong recommendations, and manage uncomplicated blunt extraperitoneal bladder injury conservatively, and manage intraperitoneal injury caused by blunt trauma by surgical exploration and repair. We have to manage small, uncomplicated iatrogenic intraperitoneal bladder injuries conservatively. This we just discussed. And when not to perform a cystogram, do not perform cystogram to assess bladder wall healing after repair of a simple injury in a healthy patient. In this case, we do not require a cystogram. And cystography has to be performed to assess bladder wall healing after a complex injury or in case of risk factors for wound healing.